Here is the question.
Okay, next slide.
Yes. Doctor, someone would be helping you.
Right. SAU means?
Surgical acute unit. I think.
Okay, next.
Yes. Surgical assessment unit. Good. Yeah, I forgot.
Next.
Yes. Is it the next? Yes. Sorry. Yes.
Next.
Yes.
Next.
Yes, please.
Next.
Yes. Please.
Next.
Yes, this is it.
Well done.
Yes.
Okay, I'll just need 1 minute to compose
Yes.
things.
I couldn't write abdominal symptoms and signs unchanged.
How much
That
time
is.
has been?
You still have 4 minutes.
Okay. What are the abdominal symptoms apart from
Patient
pain? Any tender areas
tenderness.
or
Yes.
In which area? Left, right, hypochondrium, suprapubic.
Severe abdominal pain. I didn't write that.
Generalized.
I think
Okay.
I forgot.
Generalized. Right.
Or it's not given in the notes. Generalized, yeah.
Gender of the patient or name?
Man, 58 years old.
Any name of the patient?
I didn't name anything, yes.
Okay. Let it be Tom. Okay. Any labs done? Any lab reports pending?
Yes.
Apart from the CT? Apart from CT?
Just CT. I mentioned all the labs. Okay, this was my first trial anyway. Okay. Labs I've mentioned, I have missed.
Next slide. I think we can start.
40 seconds left.
How much time gone?
34 seconds left.
Okay. Whom I have to talk?
Your on-call consultant. I have requested one person here. Yes, so if you have read and understood, kindly begin.
Yes.
Dr. Vajia
Okay.
will be your consultant.
Okay. Great consultant. Okay.
Yes.
So,
Oh, she's not here, or? She's
No, I'm
here.
listening,
Okay.
everyone.
Yes, please begin.
okay. So, hello. I'm Dr. Nadeem, one of the surgical candidate. Whom am I speaking to, please? Can I please know?
Well, you just called me. I'm a surgical consultant, Mr. John.
That's right. Nice to call you. May I please take few moments of your schedule? I have to discuss a patient, important patient, 58-year-old male, Tom, who presented to surgical assessment unit. Can I?
Yeah, go on. I'm listening.
Okay, right. Thank you. So we had a patient, 58-year-old Tom, male, who has hypertension, rheumatoid, and hypercholesterolemia. He presented with 1-day history of abdominal pain, which is increasing in severity, and it is generalized, and there is also generalized tenderness. While the vitals on first day, yesterday night, showed uh, mild temperature increase of 38 degrees Celsius, and there was tachypnea of 24 per minute, and pulse rate was quite high with 120 per minute. Blood pressure was maintained with 3 liters of crystalloids given at that time, which was 110 by 70 millimeter of Hg. He was also catheterized, and urine output was only 40 ml in initial 2 hours. CT scan was done, and the report was still pending. Now in the morning, there is increased abdominal pain, and there were also 3 episodes of vomiting in last 1 day, and the urine color has also changed to dark color, along with change in color of the skin.
What are you worried about, doctor? Why you called me?
Yes, I'm worried about further assessment of the patient, as he is still on today's vitals. Still, the blood pressure is only 110 by 70, and there is still tachycardia of 120 per minute, and the urine output is still not maintained much, and the pain is increasing more. It has not settled yet.
What are you worried about, doctor? Why you called me? There's a man with a 24 hours history of abdominal pain and vomiting. What are your
Yes,
differential?
I just need your further input in the management. Like, this was the management which we have done so far. So it would be great if you could guide us further.
What are your differentials for this patient?
Well, the patient, let me explain you a few more things. Like, the patient has a history of heavy intake of alcohol of up to 20 units per week. And now he's on medications like prednisolone and other medications for blood pressure, thiazides, and simvastatin. So these are some things which I needed to mention. And he is overweight with 96 kg. Now, my differentials are pancreatitis, peptic ulcer disease, peritonitis secondary to perforation, duodenal perforation, and well,
Why
these are my
had a
and
pancreatitis?
cholangitis
Why do you
or
think?
gallstone.
Why do you think he has pancreatitis?
Yeah, because owing to the obesity, heavy alcohol intake, and the abdominal pain, along with change in color of skin, darkening of the skin color, and also vomiting.
What do you mean by darkening of the skin color? Do you get that with the pancreatitis? Does he has a Cullen signs or Great Turner sign?
Yes, if oh yeah, so that's fine. You're right. So it's great renal sign, and there may also be hyperbilirubinemia. I don't have the laboratory test yet, so I cannot comment on that.
Why do you
We,
think he has
we have,
pancreatitis?
but as far as the sign color is concerned, yes, it may be great renal sign, which may be due to hemorrhagic
Can you
pancreatitis.
mute Dr. Nadeem? Can you mute Dr. Fatumata? I have no control, so Dr. Nadeem, can you mute her?
Okay,
Thank you.
Why do you
I
think
got
he has
something.
cholangitis?
Sorry. Okay, so maybe if there is due to heavy alcohol intake and obesity, there may be gallstones, which might be leading to cholangitis, or this pancreatitis due to secondary to gallstones.
Okay, and you have resuscitated the patient so far. Is he stable now?
Well, still he is tachycardic. His BP is maintained, but and capillary refill pressure is also 3 seconds, but still he is tachycardic and also tachypneic. So you may need further management.
If he has gallstones, what's the best mode of investigation we use to diagnose it?
Well, ERCP is the gold standard because it will not only be diagnostic but also relieving the obstruction by putting a T-tube and also removing the stones later on
But we don't
with
know yet
secondary
he
electrointervention.
has gallstones, right? We don't know yet he has gallstones. So how you diagnose gallstones?
Yes. So, yes, okay, that's fine. CT scan report is still pending. We have to see on that. if there are any gallstones, and we can also do ultrasound before that.
Yes, so you do ultrasound scan. If ultrasound is not clear, then what's your next choice? To diagnose it or to look at a clear?
Well, I'm waiting for the CT scan. Stones will be pretty clear on that.
Okay. So CT scan will show us if he has a perforation or not. So it can exclude a broader view, but essentially this patient needs an ultrasound scan, right? And then maybe MRCP and ERCP later on. Have you done any
Okay.
bloods on this patient?
Have I done what? Sorry, please
Blood.
repeat.
Have you done any bloods on this patient yet?
So I don't have the information yet. So I have to confirm, and I'll get back to you.
Which blood investigations you will be looking for?
Well, I'll be sending the baseline investigation if they have not been sent, or we'll be looking for them like CBC, serum electrolyte, renal function test, amylase, lipase especially, glucose levels, BSR, and calcium levels, ABGs for oxygen saturation,
Will you
and
do
renal function test,
profile in this case?
and this albumin levels and liver function test.
Will you do coagulation profile?
Yes, I will do it.
From the story, it looks like he has obstructive jaundice, isn't it?
Yes, it might be the cause, but I have to confirm it
Yeah.
after the results.
So, do you know the causes of the obstructive jaundice?
Well, it can be either due to gallstones, uh, cholangitis, or stricture of the common bile duct, or any duodenal cancer, or growth, or any pancreatic cancer.
Pancreatic cancer. Right. And so we are waiting for a CT scan. What else it can be? What other concerns you have?
Well, it can also be peptic ulcer perforation, because peptic ulcer disease leading to perforation because there is heavy history of drinking and also prednisolone use in the past for rheumatoid.
Okay, if we don't have a CT scan, what do you think? How we can proceed forward then?
Okay, if the patient deteriorates further and there is high TLC count and he goes into sepsis, then we might have to open open him up after finding any gas under the diaphragm on X-ray abdomen.
Okay, and who you want to get involved in case he deteriorates?
Okay, I'll let the I'll also inform you and the anesthetist and the emergency operation theater manager for the list, and also the critical care consultants or the ITU registrars.
Well, you have informed me, so thank you for that. So because he's on the ward now, so you think from what you have told me, looks like he's deteriorating. So it better be you call the ITU or outreach to come and see the patient. Give a call to the radiologist to expedite the report, speak with his family, and examine the patient, send some blood investigations, and I'll be on my way. Okay? Thank you.
Okay, thank you so much. Should I repeat some things, a few of the things, just to confirm that
Thank you.
I have understood you? Thank you so much.
I'll be on my way. Thank you.
Okay, thank you. Welcome.
Good. Okay, yes. So we'll begin with Dr. Nadeem himself. So what do you think? How was it? Was it as easy as you anticipated, or was it difficult for you to manage?
It's 50-50, like it needs practice, seriously.
Yes, honestly speaking.
It is only a matter of practice.
Yes. And
few mistakes